get my thing opened. hoping they do, so that way they take me so seriously. This is on. Hi, Janice, can you hear me?
Yes, I sure can. You look very cute today.
The Santa Claus costume is too much, even with the little beard.
I think it's perfect.
All right, just gonna check with you. Did all the. All right, so this starts at noon, right?
Yeah.
Okay, so I'm gonna turn my video off for a few minutes because this is uncomfortable, and otherwise I have to have the beard. Then everybody will know Santa Claus. Ooh, better get off. Okay, I'll see you in a bit.
Okay, and I'm gonna go grab some lunch.
Okay.
Hi, Carissa. How are you today?
I'm fine. How are you?
Pretty good. Thank you for talking today.
Oh, hold on. I'm getting on there. Just a second. I gotta get my get up already.
You're fine. We're early. I just wanted to say hello. We still have quite a few that need to get on.
All right, Santa Claus is here. He's doing the
You are too cute.
I'm gonna get real hot while I'm doing this.
Oh, that's great.
Love it. How fun.
We gotta cheer everybody up because everybody's kind of like in this kind of sad, I don't get to see my family members kind of state right now. So
Yeah.
we're gonna do the best we can, right?
Yep, exactly.
Change this to Santa Claus.
So they think you're Santa Claus?
Yep.
And they don't.
Pretty much, yep. So they'll like this class and they won't get bored. All right, it's about 2 minutes. We'll get ready to start. Just so you know, the clock is ticking.
T-minus 2 minutes.
Yes, 2 more minutes. I got to wear this really hot thing. It's really hot in this thing. If you have a very big beard, it does keep you warm apparently, but you probably get hot faster.
Could you imagine being Santa for all weekend?
I know. Whew. Although I make my husband do this every year. We do this thing called Santa's Helpers. This is why we have this suit. And we go and deliver presents every year to kids in need. And of course he has to wear the suit and he complains about being hot all the time. And now I really know what he feels, you know. So, Cass, it looks like it's really difficult when I have these slides on to read any any comments in the chat. So if there's something that comes up, please just let me know.
Sure, yep. Steven says he'd like for you to teach all of his lectures.
I don't know if I can be through all this. It's so hot. Look, I even have gloves, but I can't, they don't work very well with the computer.
For those of you that are on the lecture already, I'm going to put the link to the MAHEC form in the chat, and I'll leave the meeting on for a while after the lecture is completed so everyone can access it. And hopefully this month I can get the link right the first time.
Thanks, Marcy.
Welcome. And I'll put the program ID in there too, because it's different for every lecture. So
Sure.
All right, hello everybody. It looks like we're starting. I'm Santa Claus. I'm doing the lecture today, and we are going to talk a little bit about evidence-based practices for substance use disorder, knowing that a lot of you are working in a health or hospital setting. This gives you kind of an understanding of how the delivery system works a little bit. But then we're going to focus more heavily on a very well-known intervention called motivational interviewing. And some of you may have gotten some motivational interviewing skills training, but really, you know, there's a very important pedagogical theory that if you get this repeated over and over again, you get better and better at it. So you really have to continue to brush up on these skills and have these elements of motivational interviewing reinforced, because one training is really not enough. You need some booster shots on this. So we're going to start first. Oh, I can't wear the gloves. It just doesn't work. With inpatient and residential treatment. And so one of the things that people hear a lot about is therapeutic communities. And this is kind of where a lot of treatment had been in the late 50s. And this is kind of where a lot of when they started actually having treatment for substance abuse disorders, what they were doing. They did something called these therapeutic communities. And really what these were they came out of the 12-step movement. They're highly structured programs. And the person would go into them and they would stay there in residence for 6 to 12 months. And they would be part of this community that was where every part of the community was sort of an active agent of change. So there was this essentially kind of this peer aspect of substance use disorders was really kind of a very important part of it. And the length of time was also important. So essentially with the one plus about therapeutic communities was a recognition that substance use disorders actually isn't something that can be just treated in a very short period of time. You do need to have, you need to have services that kind of wrap around your entire life. And so housing is a really important part of that. Having a social network is a really important part of that. But there's some weaknesses to therapeutic communities. One of them is that they were very traditionally 12 steps. So they wouldn't even let people use medication at any time. We know with opioid use disorders, people are much more successful if they have access to buprenorphine. And, they were more expensive. And there was also sort of a perspective, they didn't have as many professionals in them, and there was issues with coercion that can be problematic. In the 90s, the treatment was more geared towards people with co-occurring psychiatric disorders. This is also kind of partially because there was more resources that were going towards people with severe mental psychiatric problems. A lot of times also these therapeutic communities were kind of created within correctional institutions, because again, you can get all the other offenders to be these peers. And you can also have correctional officers facilitate a lot of the structural parts of these meetings. So you didn't really need professional staff. Now also, there are different requirements for a lot of treatments and reimbursements. So there is more of an emphasis of incorporating professional staff. And I think one of the really important parts of this is you really do need the professional staff to give to some degree some supervision of some of these peers, because sometimes they can just go all over the place. Shorter term residential treatment is more of a thing now. So basically, if most of the time when you are going to give a referral for somebody who has a severe substance use disorder, it's to something that's shorter term. And generally that's about, they say the 28 days. So it's around a month, but a lot of times it's even shorter than that. And these treatment centers generally focus on detox and then some initial intensive counseling, and then kind of a lot of like this discharge planning. Like, okay, what's going to happen when you go back into the community? There's also a lot of these shorter term residential treatments work in tandem with recovery housing when it exists. So one example is like Oxford housing and sober living facilities. These are usually supervised short-term housing for individuals. They a lot of times will, they kind of are similar to like a house or a rooming house where people get their room. Sometimes they may have to share a room, but the room doesn't have a kitchen, it doesn't have a little bathroom, they have shared living quarters. But so there are limitations. It's not the greatest. You don't get the privacy that you want, so it can wear on people, but it does help people make a transition to independent life, and they can save some money, they can get a job, they can kind of get some normalcy in their lives. So, two of the interventions that I think are really important for healthcare workers to know about are motivational interviewing. And these are kind of ones that are really kind of more geared towards affecting people's motivation. So one of the ways that you do that is by kind of trying to manipulate their readiness to change. Another way is how you use reinforcement mechanisms. So what you decide to reward and what you decide to punish. So, one of the things before we get into motivational interviewing and how you affect motivation is contingency management. And this is often a way of creating reinforcements that positively affect people's behavior. So one of the things that we are finding more and more with health and social services is that people tend to respond very favorable to specific types of reinforcements, whether they be negative or positive. And that positive reinforcements, especially if they are, it's getting hard to breathe. It's positive reinforcements, especially if they are automatic and they happen very quickly, very simultaneously with the behavior taking place, are extremely effective. So the idea is essentially with contingency management is that you basically reinforce positive behaviors relatively quickly, and you do that with specific types of rewards. And these rewards can be anything. They can be like bus tokens, they can be little gift cards, they can be whatever it may be to encourage positive behavior. And so they've found that with people with substance use disorders, this is actually particularly effective because you could think about something like a drug or alcohol. It gives that real automatic positive reinforcement. So if you find ways to replace that, many people with substance use disorders are able to make a lot of very rational choices related to it. So voucher replacement is one of the ways that this is done. So food items, movie passes, activities consistent with a drug-free lifestyle. You can also give prize incentives like vouchers, like lottery. So these types of trying to figure out when you have individuals who are within your health systems how to build in contingency management programming into your practice is a pretty clever way of improving outcomes. So let's get over to motivational interviewing, because this is why you're here, right? So motivation, what is motivational interviewing? Well, one of the things is collaboration is really important. And I think a lot of times people make a mistake with motivational interviewing because they assume that you just take a really passive approach and you let the patient kind of control the whole situation. But that's not really where we're going here. The idea is that you are bringing something to the table as a health professional. You have the level of professional skill. So there's a lot of knowledge packed in there that you have to offer this patient, and they're coming to you for a reason. It's not just for you to like sit there and ask open-ended questions that are very, very broad and overgeneral. It's a back and forth where you have specific knowledge they need. And so also want to think with motivational interviewing is that there's a lot of attention to the person changing their behaviors. And it's designed to strengthen personal motivation and commitment to specific goals. But you have to really do that from that person's own self-determined spirit. They have to offer their own reasons. You can't give them reasons. Also, motivational interviewing, and this is something that doesn't really come with every single person. They don't always kind of spill over with empathy and acceptance and not being judgmental, but you can't really do motivational interviewing right if you're a judgmental, arrogant person. Like, you have to work on that in order to be able to do this skill. So some of the skills that you learn with motivational interviewing is to articulate. You provide sufficient detail and context for true communication to occur. So what does that mean? That means when you ask very open-ended questions, but then you kind of act as a sounding board. You use sort of something that they call reflective listening to reflect back what somebody has said. But it could be just sort of in a different way that leads towards change. So again, you're manipulating the situation to increase motivation. Attentive. So very important that you are very present in these communications. This is somebody's, this isn't just some, regular, flu shot type situation. This is something that it totally is the center of somebody's life. So kind of half listening is not the way to have this conversation. You need to sit down, you need to follow nonverbal cues, you have to look somebody in the eye or somewhat around that perimeter and be there. You also, I use the word manipulation. I think it's just because it's an easy placeholder in the situation, because in a way you're doing that, but the reality is it can't appear that way. Authenticity is really important in this. Somebody has to feel like they're talking to you as a person, not necessarily as, an authority figure. So there's parts of your personality characteristics have to come through. The person is not talking to a robot about their most important life choices, and how to change the trajectory of their life. They're talking to someone that they kind of have some ability to relate to. And again, when we say this, this is supposed to be a collaborative thing. You have to recognize what you're bringing to the table. Granted, you may not have had a substance use problem, and you may look at folks with substance use disorders with a little bit of intimidation, like, wow, this person has had a really rough life, and I don't know what I can teach them. But that's not true. You know a lot of the biology of what happens when people do things to their body that they shouldn't do to things to their body. Also, again, I can't underestimate enough, empathy is a huge part of this program. And this is different from using the words, using something like sympathy. Empathetic means you basically are relating to the behavior as it comes about. And you do that in a way that you are non-judgmental. That doesn't mean that you are allowing bad, you have to kind of think of this differently than you're allowing bad behavior to happen or excusing it. You're not in that position to do that, but you are basically talking to this person in an objective way. So empowering, basically the assumption that you believe people are actually capable of changing. Now this is big. A lot of folks are under the impression that if somebody gets a substance use disorder, or if they're having serious problems with substance use, that they're kind of a lost cause. You know, they're just going to get to the point that they kill themselves. But you can't, and that, or they have there's another kind of stigmatizing belief that if they have substance use disorders, there's weaknesses on the part of themselves. And so if you're coming with that perspective, you're not going to be able to talk to this person in a way that you're thinking about what strengths they have and how they're going to be able to meet these challenges. So another thing that is a competency that needs to be built up is flexibility. So you pivot with the person's life situations. You pivot with where the conversation goes. You can't be rigid about this. It's gonna, what happens a lot of time with people in motivation is it wavers up and down. People go back and forth. They a lot of times don't know what to do. So they see that there's good things about this behavior. They're getting to hang out with a group of friends they really like. When they take the drug, it makes them feel good. And then there's bad things, like they're losing their job, they're gonna get thrown out of their apartment, you know, they feel like they actually work a full-time job just for this drug. So, you know, how much they value each of those things goes up and down. So you have to pivot with that. Again, people oriented, and you need to care about these folks. You know, you also have to be clear about consequences. And so this is kind of part of like the non-judgmental issue. It doesn't mean you necessarily say, we're being non-judgmental, we're letting you do what you want. If you have authority over something, like if you're a physician that is able to give medication for opioids, and you don't want to have to give medication to them anymore, you have to be clear about that. And again, reinforcing progress towards change. Respect your folks. People feel that when you don't respect them. This goes into the whole arrogance thing. Like you really need to work on respecting people and respect how difficult it is to become sober, especially after long periods of time. Again, sense of humor, you know, you even see this with this, it makes everything kind of a little bit brighter and funner. You want folks to actually want to come meet with you. If you're rigid and difficult and arrogant, nobody's going to want to see you, you know, and they're not going to really want to talk to you. And, you know, encourage what they're good at and look for things that they're good at and use those to say, yes, you can do this. So one of the important parts of motivational interviewing is figuring out where people are in terms of motivation. So this is kind of where you think of this in a diagnostic type of way. So, you know, there's basically 6 stages of change. There's pre-contemplation, where a person is in complete denial. Contemplation, they're ambivalent. Determination or preparation, and this is where they're starting to move in this direction of change. Action, we're gonna go, doing it. Maintenance, living it. Relapse, all right, well, I guess we gotta start over again. So I'm gonna kind of go a little more slowly over these because it's really important. You can, because when you talk to people, you kind of get a sense of where they are in the stage of change, but there's also things that you need to do to ensure that they go in the direction you want them to go in. So pre-contemplation, this is where the person is not seeing a need for a lifestyle or a behavior change. Your job here is to raise doubt. So you want, and this is really where the medical knowledge that you have is really important, or the behavioral health knowledge that you have is really important. You increase the client's perception of, increase the patient's perception of risk and problems with the current behavior. And you validate their lack of readiness. So you say, I understand you're not ready, but these are some of the risks that you have to deal with. Don't make them do anything right now. Big important thing to do during this pre-contemplation stage is build rapport, clarify that the decision is theirs, encourage them just to think about their behavior. So next stage is contemplation. And this is where the person is thinking about making a change, but they haven't made a decision yet. So they're not exactly there. And this is where you kind of like, if you really hear them once say they're going to do something and then they don't do it, and then you get very disappointed. This is kind of, you have to have some recognition that this is the stage that they're in. Your job here is to tip the decision balance. So what you want to do here is evoke reasons for change and risks of not changing. You can do this very well with some of your patients with like a kind of a matrix of, you know, where you show like, what are some reasons to change? And you just write down the reasons to change and some reasons for not. And just, you know, let them just kind of look through those and balance those. And when you do this, again, you're validating their lack of readiness. You acknowledge both sides and the ambivalence, and you recognize it's really their choice to make. It's not yours. Another thing you can do during this stage is clarify the decision. So what are the decisions that are in the front that they have to focus on and think about? And, you know, and you can also kind of try to, in order to kind of help them a little bit with this ambivalence, is to explore elements of change, acknowledge reasons for change, and come up with new positive outcome expectations. So this is where you brainstorm some other things. So they may have identified some other thing, some of their own reasons why they want to change, but you can also help them come up with some other ideas they haven't even thought of. And again, you know, if you have already established rapport with them, and then you also know some things that they're good at, you can use some of those to kind of encourage them, essentially. So next one we have is preparation. And this is where the person has decided to make the change, but they don't really quite know how to do it. Or they're considering how they're going to do it and how they're going to work it into their life. So your job here is to help the patient determine the best way to go, the best course of action in seeking change, and to work with them to develop an actual plan. So when they see it on paper, it becomes clear to them, it's easier to kind of follow that. So it's really kind of making it concrete to them. So here you're identifying and assisting in problem solving. This is a big part of the coordination of care and working with those folks who are able to understand these care systems and how to get people the care they need. So if your facility isn't able to provide this care, that you're able to get them where they need to go. And when you think about this, also you get them where they need to go in a relatively easy way. You don't create, you try to reduce the obstacles as much as you possibly can. Another thing you can do during this time is provide a menu of options. And so if you create this collaborative plan, you give the patient some ideas, you know, of, okay, if this doesn't work, do this. And then come to an agreement. What do you think is gonna work? Another thing is you keep attending to presence of ambivalence. Just because they're in this preparation stage doesn't mean that ambivalence can't come back. And you help the patient identify sources of social support. So you want them to know who is around them that's going to help them, because this will make it easier for them when they're kind of in this like stress, these crisis stages, to automatically have this stuff set aside and able for them to kind of grasp onto. And then another thing you can also do during this is you can encourage small initial steps. So it can be like small things towards reducing their use, just to kind of get them towards where they need to go. All right, we're in action. And this is where the person is actively doing something to change. Here, you basically help them implement their plan. And when things come up, you help them with problem solving, and you support their ability to do this. So you support their self-efficacy. You stay connected to them. If they have any kind of slip-ups, you just revise the plan so that it's realistic, because maybe they were just being unrealistic. And so maybe you want to think about how best we're going to do this. Focus on restructuring cues and social support, bolster self-efficacy and dealing with obstacles, and combat feelings of loss that they may feel. So, you know, for a lot of folks that have substance use disorder, they build social networks around that. And there is a bereavement and loss around some of those social networks that you need to acknowledge and figure out with the patient, how are they going to deal with these feelings. But, you know, when you do this, you also reiterate what the long-term benefits are. And one of those is they'll build new social networks that are much more healthy. All right, so the person is maintaining a change or a new lifestyle. But, you know, there may be some temptations, and they may, you know, to return to the former behavior, or there might be little small lapses. Your job here is to help the patient identify and pursue strategies to prevent relapse and to resolve associated problems. So basically, some of the plans that you maybe want to make is plans for follow-up support, reinforce internal rewards, and discuss preventing and coping with relapse. Oh, they relapsed. Oh no. Well, what does the provider do now? Well, they help the patient recycle through the stages of contemplation, preparation, and action without letting him get stuck or demoralized. So, okay, you made a mistake. It's not the end of the world. Let's just get back on the train. Some things they could do is explore what went wrong with the maintenance plan, learn from this situation, and revise the plan. They can evaluate triggers for relapse, reassess motivation and barriers, and plan stronger coping strategies. Oh, so here's hold on, bear with me. Here's a really cool stages of change video that maybe does a better job than me, but let's see. They could definitely draw better than I can.
I'm Dr. Wendy Guess, here to explain how using behavioral science can change your life. Have you ever really wanted to change something in your life, but it didn't work out the way you planned? Maybe you wanted to eat healthier, or exercise more often, or get rid of a bad habit. You made some goals, you tried to change, but in the end, you were not successful and you felt frustrated and stressed out. Well, here's some good news. The science of behavior change can help you succeed in changing your behavior and as a result, have a better life. Behavioral scientists have found that people who go through a particular process to make a behavior change are more successful than those who don't. That process is called the Transtheoretical Model, or simply the stages of change. Let's learn about these stages to help you succeed in making a positive change in your life. Meet Isabella. She has a challenging job and often feels tired and run down. One day, her friend asks if she'd like to join a fitness walking group, but Isabella doesn't see the purpose and explains that her schedule is too busy. Isabella is in stage 1 of the Transtheoretical Model, the Pre-Contemplation Stage. For her to move out of this stage, something has to happen, something that makes her think. One day, Isabella reads an article that helps her realize some of her habits really aren't healthy and could lead to serious problems later in life. She begins to consider the pros and cons of making a lifestyle change. Now, when her friend asks about walking, Isabella says she'll think about it. Isabella is now in stage 2, the Contemplation Stage. As Isabella contemplates further, she starts to talk to her friends and colleagues about how she might fit a regular walking program into her busy schedule. She also researches what she might need for walking, as well as the benefits she can expect, such as better health, more energy, and increased endurance. Isabella is emotionally and mentally preparing herself to change her lifestyle by increasing her self-efficacy and building her determination toward adopting this new behavior. She's in stage 3, the preparation or determination stage, which will empower her to make a change. Now that Isabella is prepared and determined to make a change, she takes action by joining her friend's walking group. After a month, Isabella is doing very well and starts to see her results in her energy and daily life. Isabella is in stage 4, the action stage. But when things get a bit hectic at work, she stops walking for a week. Fortunately, her group leader understands the challenges people face in the action stage and shares some motivational material to help Isabella get back on track. Over time, Isabella becomes more consistent and confident with her walking activity and starts feeling better than ever. Fast forward 6 months, we find that Isabella is consistently maintaining her new lifestyle. She feels great physically, handles daily stress with more ease, and has more energy than ever. Isabella is in the 5th stage, the maintenance stage. She has built a supportive network by getting friends and family to join her walking group, and that helps her focus on preventing a relapse back to her previous behavior patterns. Each stage of the behavioral change process presented new challenges, but when Isabella worked on her internal attitude changes, she was able to make the external behavioral changes that she desired. Now she's thrilled with her healthier lifestyle and all the benefits that come along with it. Congratulations, Isabella. We all have behaviors that we want or need to change. Using behavioral science to understand the change process will help you be more successful with changing those behaviors. That means a better you and a better life. I'm Dr. Wendy Guess. Thanks for joining me. I'd love to hear about your journey to a better you.
All right, well, that was Dr. Wendy Guess. And sorry about that, my stomach made the thing slide, the thing stop. That's what happens with Santa Claus. All right, so we got a little interactive piece. I don't know if everybody could see this, but I'm gonna read off some of these different situations, contexts, and we're gonna see if people can let me know what stage of change they think they're in. And again, sometimes it's not exactly clear. Sometimes there can be a little bit of overlap. So just to let you know that. So, all right. Oof. We have a 17-year-old has been drug-free for 4 months and attends drug and alcohol group weekly. What stage of change is that person in? Anyone want to volunteer? Or do I need to call people?
We have maintenance from Nathan.
All right, great. So what about a 16-year-old girl has started calling her aunt each night to check in and get support. Also made an appointment to meet with her counselor. That one's a little bit harder.
We have contemplation from Jordan.
I think this might be action because she's actually doing something. So she must have some sort of plan. But I agree, it also may be, contemplation because she's figuring out who her support network is. Or preparation, it may be preparation because she's figuring out who her support network is. All right, what about a 17-year-old says, I'm going to be more organized so I can get all my hours of community service done and keep up with my schoolwork.
Preparation? Maybe?
Yeah, I think that's preparation because they're making this plan, right? All right, we'll do one more. A 15-year-old is on probation for the second time. He says that getting into trouble and being on probation takes up too much time, and he could be making money. What do you think?
Liam says contemplation, so does Stephen.
Okay, I think it's contemplation as well. Because there's not really a plan there, but he's starting to see the negative aspects of his behavior, right? All right, all right, so again, here is sort of to reiterate some of what you need to do based on what stage people are in. So, big part of when someone's in pre-contemplation, they're sort of in a denial stage. You really want to just engage with them. You want to deal with any kind of crises that come up, but building the relationship is a really important part of that. Assessments are also a good thing to do during this time. There's also something they talk about, functional analysis. So functional analysis is also where you get into all the causes of something, but also some of the risk factors that are going to happen. So getting into some of the risks of the behavior that they're in. Contemplation, preparation, again, this is where you're persuading. You're doing education, goal setting, increasing awareness of the problem, skills training, family supports, peer support. Action is this is where the treatment actually happens. So this is when they get into treatment. Your role as a provider generally is to support this, but if you are actually the person giving it, so a lot of the treatments, especially the behavior treatments, function on sort of this functional analysis where we look at what the cause of the problem is, what the effects of the problem is, and then some skills training where people deal with relapse prevention skills training. And then, maintenance is essentially prevention plans, continued skills training, and expansion to other areas. So basically what we went over was that, motivational interview is more than a set of technical interventions. It's essentially a way you're with your client. And there's different kinds of aspects to it. And one of the ways we think about this is partnership, autonomy, compassion, and evocation. And how all these things kind of, overlap to kind of create this spirit of motivational interviewing. Partnership is where you collaborate. Autonomy is where we don't make people do things. We accept that we actually are not in charge for them. People have their own paths. They're grown-ups, you know, they're not children, and they're not our children. Compassion, you give priority to the client needs and welfare. And then evocation, the resources for change and motivation reside in the individual. You know, you're not going to be so great of a doctor or a counselor or whatever have you to make your patient change. The fact that that patient change is about them and their ability and willingness to do it. So again, kind of went over these a little bit, but let's kind of go over some questions. So one of the things that you do within motivational interviewing is that you ask lots of different questions. And the idea is to have questions that are very open-ended. And, you know, they want you to kind of have these questions that go along these kind of partnership, evocation, acceptance, and compassion frameworks. So here are some ways you can ask these questions. Like, what concerns you most about your drug use? Or what concerns you most about your diet? Or you can also kind of do this evoking question in a different way. Looking back, do you remember a time when things were going well for you? And then you could kind of, when you use these kind of questions, you can get them to be more broad about what was going on and then pick up on those. This also kind of gives you some clues that you can use to kind of reinforce their self-efficacy. Oh, it looked like you did this very well. Oh, I think that you can apply that here. Looking forward, if you decide to make this change, what do you hope would be different in the future? So again, this is kind of where we can reinforce their idea of what's going to be a positive outcome. So when you do this, these open-ended questions, you really want it to be open so that the person gives the detail, not you. And you want them to give the more detail and the more examples, the better. Affirmation, you know, important that the person gets positive reinforcement for doing this. They don't want to get reinforced with judgment or negativity. And basically reflecting is where you reflect on what they say. So, you know, you basically go, oh, I heard this, and this. And summaries is where you summarize it, but the summary that you have is tilted towards a change behavior and change talk. With open-ended questions, I think we kind of covered this, but you know, it's really important to design them to be intriguing, because even if the person doesn't answer them, it makes them think. So the idea is just to kind of like be very mindful and clever about how to place these open-ended questions. This is when I talked about like some sort of matrix. So this is something to really think about using when somebody's in in sort of this contemplation stage. You know, what are the good things about this behavior? Why are you doing it? You know, and you know, have them list it. And what's the good things about changing? What are the not so good things about this behavior? What are the not so good things about changing? So, I mean, this way they are able to kind of consider all the different parts of this. And really, you can have some of your own hesitation. Oh, well, they're going to fill out this list and they're going to decide they really want to keep doing this behavior. But when it really comes down to something like a substance use disorder or a really poor diet, you know, I think you need to just have faith in the person that they're going to come to this conclusion that it is negative. We know that's where the data leads, is that people do not enjoy being in these circumstances. People don't enjoy being sick. When you affirm people, and so when I say, again, you really want to look for clues that you're reinforcing these behaviors, especially if you're a member of the community, the medical community. There's a lot of respect for people who are within the medical community. And what oftentimes when people come and they see you, they really, it's just, they're so in awe that if you say something nice back to them, that's personal to them, and that really feels specific, they really take it to heart. So think about when you make these affirmations, they're not just kind of willy-nilly, they're really meant to build self-efficacy towards their change behaviors. So you want to inject hope and you want to strengthen the rapport when you're doing it. So reflective statements, so how much time we have. So this is a little bit more complicated part of doing motivational interviewing. This is where people sort of struggle. And this is essentially, you use a reflective statement to kind of land on, augment, and highlight any change talk that you hear from the client. So this is where you're just kind of listening for when they bring change talk. And then you reflect it back to them. Oh, I heard you said this, this, this. So it's not exactly like a summary. You're much more selective here. And it typically leads to an open-ended question. Both of them are highlighting or reinforcing change talk. There's a great video on this. I'm not going to show it because it's kind of a little bit long and we're running low on time. But when you do this reflective listening, remember, you're really getting to the point of change. This is really kind of the point where you don't want to piss the person off. So don't add new information. Don't add advice. Don't tell them how you identify. Don't try to fix anything or change the person. Just concentrate on the aspects where they said change is needed and how they go about that. So again, this is a way of doing that. You could just repeat portions. You can rephrase it. You can paraphrase it. You could reflect the feeling related to it. You can play the devil's advocate, or you can allow the individual to hear himself for the second time by just using a kind of a strategy of summarizing. So there's also just the general summarizing, which you can just sort of do at the end. The change and the not change and everything in between. And this is where you tighten up the conversation. You can kind of allow it to move from one place to another. So let me sum up what we discussed here. And then name the themes that was discussed and check to see if you got it right. And you can use it to begin a new session, bridge between sessions, keep the conversation focused. So here's the deal. I came in here thinking it was just bad luck I got caught. I mean, everybody smokes pot, and I didn't know that you could get a DUI for smoking. I really hadn't smoked that much, and I just needed it for my stress. I guess I feel lucky that nobody got hurt. I'm not ready to stop smoking entirely, but I'm not thinking hard about making a low-risk choice. It's just not worth it. I'm not coming back here again. So let me summarize where you are. You are unaware that a negative consequence of smoking marijuana is that you can get a DUI. You are also thankful that no one was injured by your decision to smoke and drive. Well, one of the benefits of smoking has been to help you with your stress. You are starting to consider the risks of using because you are clear that you don't want to come back here again. It sounds like you are looking at your future. What other things would be affected if you stopped smoking? Whew, it's getting hot. Okay, so we're coming on the thing. I've got a bunch more slides. So other things, rolling and deconstructing resistance. Again, I mentioned people are going to go back and forth. They're not going to just keep on this linear path. That's how it works in the movies, but it isn't the way it works in real life. And so just, you want to keep this collaborative. So just, if any kind of issues come up back and forth, and sometimes you make a mistake and you say the wrong thing, don't fuel the fire, assess your mood, check in, and, return to reestablishing rapport. And, use reflective statements about the situation, not the individual. Oh boy. So this is also another kind of strategy within motivational interviewing. It's called DARNS, desire, ability, reason, need. So desire, how would you like for things to change? Ability, of these various options you've considered, what seems most possible? Reasons, why would you want to get to change? And need, how serious is this to you? So again, with invoking change and this evoking change talk, you can add some of these aspects into it, like the desire, the need, the reasons, and people's ability. And you frame your questions around that. Here are some examples of desire. How would you feel differently when you were no longer using? What would make you want this change? What do you want people to think about you in making these change? Again, this just reinforces the point that your questions and the open-ended questions are really encouraged to, are meant to encourage dialogue, but also people's thinking. So they may not give you an answer, but they're supposed to kind of think along these lines. Ability. Who could support you in doing this? What skills do you need to make this happen? What do you know about yourself, which tells you that you can start not using, Reason. What are some of the reasons you have told yourself about making these change? In what ways will you feel differently about yourself in making this change? Need. What might or is likely to make you stop? What have the costs been in continuing this behavior? So when you get all this together, and this is when they are in the preparation plan, preparation stage, when, we talked about how you create a plan. So, when you create this change plan, a couple kind of components to it that can be helpful. One, set goals. How would you like things to be? How do you want them to be different? What is it that you want to change? And then consider change options. And this is where you explore different ideas, and you could write down, try to list and brainstorm, and then you arrive at a plan. So what are the specifics do you plan to do? What is the first step? How are you going to prepare? What do you need to get started? Also, a good thing to do when you create this change plan, so you got this preparation person, is to figure out what their commitment to change is. So on a scale of 1 to 10, how confident are you that you can enact this plan? How ready are you to make this change? And then, when you get the score number, you can then ask these follow-up questions. So if it's really low, you maybe then want to ask, what do you need to move the score higher? Or if it's or another type of way of asking this is, what would you need for this to move the score from 4 to 8? Or if it's a little bit higher, you maybe want to ask, help me understand why you scored in the way that you did. And then you want to just kind of get some more understanding of how the timeline works in terms of change. So we're going to close with this MI preparation prayer, and then I guess I have a few minutes for questions before I fall over on the ground because I'm so hot. So guide me in a patient companion to listen with a heart as open as the sky. Oops, it says ask the sky. And grant me vision to see through her eyes and eager ears to hear her story. Create a safe and open mesa on which we may walk together. Make me a clear pool in which she may reflect. Guide me to find in her beauty and wisdom, knowing your desire for her to be in harmony, healthy, living, strong. Let me honor and respect her choosing her own path and bless her to walk it freely. May I know once again that although she and I are different, yet there is a peaceful place where we are one. All right. Okay. One thing I want to note, Cass, did I send you those MI exercises if people want to do them?
I don't think so, but if you could get those to maybe to Marcy, we could send it to the whole group.
Okay. So we do have some an NI exercise that you could do if you really want to, if you kind of want to spend a little bit more time building your skills in this. Does anyone have any questions?
We have one from Stephen. In the maintenance step, you mentioned reinforce internal rewards. Could you explain internal rewards?
So internal rewards meaning it means basically like their own feeling of accomplishment. It could also mean that the reward, basically in terms of internal, it's everything just basically having to do with their own mental health, and external and everything to do with their own individual self. So it may mean they make a little bit more money. But external is where it's people on the outside. So it maybe be, if we're talking about external, it's like your relationship with your family and then your relationship with the community.
He said, thanks. And then the only other question I had was, do you find that it would be easier for someone to relapse if they don't establish a healthy social network while they're making these changes? It might be easier for them to fall back into relapse.
Yeah, so that's kind of why during the preparation stage and even during contemplation stage, it's very important for people to kind of get for you to work with the patient on who is their social network. And so for some of these folks, they basically say there's nobody. And when there's no one that they have, my recommendation is go and help them look for a 12-step meeting. And really you just do a Google search for 12-step meetings. What's really kind of exciting about them is that they, there are all sorts of issues that people have with different 12-step meetings, but one of the things about it is that they're in every community, or just about, and if you can't access them in your own community, you can access them online. And they are at every hour of the day, and you kind of can pick your people. So, I mean, if you like this specific neighborhood or you like this group of people around this neighborhood, you go to that meeting. And you could go to different meetings till you find a group of people that you feel are, this new group of friends you want to have. So there isn't really a reason to not have people. Like, it does exist. These networks have been created specifically for this purpose because it's so important. And so there's a lot of problems with the 12-step programs, but the fact that they create these types of communities, and those communities are really actually very important to people who are getting clean.
Thank you. I'm not seeing any other questions come through, so thank you so much.
Okay, I can. Santa Claus has got some presents to deliver, so I guess I got to go too. All right, I'll try to send out that practice thing out to Marcy, and
Sure.
be also maybe might be something that would be counted as experiential activity. I don't know. but I'll send it out and you can distribute it to the group.
Thank you so much. Merry Christmas.
Yeah, you too. Bye-bye.
Bye, thank you.
Can you remind everybody to complete their online evaluation and that the program ID is 29835?
Yes, I just put the link and the program ID and the link in the chat again. So if everybody could complete that, I'll stay on here for a few minutes to make sure everybody can access it, and we'd appreciate it. Thanks.
Thanks, Marcy.
Thanks, Marcy.
Have a good Christmas, New Year, holidays, all of that jazz. See
Same
everybody
to
next
you.
year.